Awesome. Here we are at session 2 of the Virtual Pharmacy School Fair. Thank you all so much for joining. I'm just going to give it like a few more seconds for everyone to pop in. Awesome. Great. Well, thank you all so much for coming to this second session. I'm really excited about this one. Inside Transplant Pharmacy, a career at the intersection of precision, compassion, and collaboration. And our great speakers are going to be talking a little bit more about how transplant pharmacists manage complex medication regimens, monitor for rejection and infection risks, and serve as vital members of the care team alongside surgeons, nurses, and others. If you have any questions or comments as the session goes on, you can leave your comments in the chat. If you have any questions, you can put them in the Q&A box. If there is not enough time at the end of the session to answer all your questions, we encourage you to go to the Rosalind Franklin University booth in the expo, and then you can chat with our speakers some more. But otherwise, hopefully we can, you can always put your questions in the Q&A box. So without further ado, I'll hand it over to our speakers to get started.
Thank you so much, Danielle. Hi, everyone. My name is Jamie Dillig. I am the Director of Admissions at Rosalind Franklin University College of Pharmacy, and I'm really honored to be introducing Dr. Kathleen Cunningham, who is a transplant pharmacist and has many years of clinical expertise in the area of transplant medicine. So I'll go ahead and turn it over to Katie.
Thank you so much for the introduction and for having me today. I'm so excited to talk about what has been, the biggest part of my career in being a transplant pharmacist. Definitely not what I envisioned when I first went into pharmacy school, but on my rotations in my 4th year is really when I got introduced to the field of transplant and transplant pharmacy, and it really drove me into going into my residencies to complete the training for this and then being a transplant pharmacist. I find it an incredibly fascinating, rewarding field. So excited to share more with you. There's our credentials on here. So we'll talk about the importance and impact of transplant in general on patients' lives. We'll go through the process of organ donation and transplant, and then I'll focus on some of the roles the pharmacist has within the transplant team. And then we'll go through an example of like a med list that a patient would get when they're discharging after a transplant, and then briefly review the pathway to how you could become a transplant pharmacist. We're going to skip over, this will be in the slides, but it's a story about a nephrologist who ended up becoming an organ donor. It's pretty incredible. There's a lot in the media about, transplant and outcomes for patients. But really, some of the stats on this slide are incredibly surprising, I think, if you don't know a lot about transplant. But about every 8 minutes, someone gets added to the transplant waiting list. And about 13 people die every single day just waiting for an organ transplant. There's more than 100,000 people that are currently active on the transplant waiting list, hoping every day to get that call that there's an organ available for them. In 2023, there were about 46,000 plus transplants performed, and one organ, eye, and tissue donor can save and heal more than 75 lives. So really just the impact of it is so great for people that become an organ donor and give that gift of life to other people. There's 2 tables here. On the left, you can see our patients that are currently, or as of September 2024, that were on the waiting list and what organs they're actually waiting for. So by far, most patients are waiting for kidney transplants. You can see almost 90,000 people. After that, it's liver transplant, and then heart, and then kidney, pancreas combined, and then lung and pancreas. And then on the right, you can see the number of transplants that were actually performed in 2023. And so, based on how many we have waiting, we can see that the kidneys are far representing the most amount of transplants that were performed, with a little over 27,000, followed by the liver, and then heart, lung, and so forth. So we know, if you don't know someone that had a kidney transplant, which you maybe don't, but there's a lot of celebrities out there that have too. One that comes to mind is Selena Gomez. She got a kidney transplant for her history of lupus that was donated by one of her best friends, and is clearly thriving and doing really, really well out there. These are like actual plush organs. They're like little stuffies. I see patients come into the hospital with them actually a lot. And they represent the organs that we actually transplant. So we have the heart, the lungs, the intestine, kidney, the liver, and the pancreas up there. So they're really cute. Mostly I do see the kidney, but we have them in our office sometimes too. So there's different types of actual organ donors. So shifting gears a little bit. So you can have either a living donor, and that's only for certain types of organs, generally for kidney and liver, where someone can actually donate their organ to another person. And so this could be related or unrelated. So for example, if I was donating to my brother, that would be a related transplant versus if I was donating to my husband, that would be unrelated because we, don't have any of the same genetic makeup. You can also do directed or non-directed. So if I know that I want to give my kidney to a patient at Northwestern Memorial Hospital, I can do that. I can make that directive. Or if I just want it to go to anybody, then it can be non-directed. And then we have these things called kidney paired exchanges, which are pretty amazing. So for example, if I want to donate my kidney to my husband, but we aren't a good match, and then there's another pair of husband and wife that want to donate to each other, but they're not a good match, then I could donate to that other person's husband. And then, for example, that wife could donate her kidney to my husband. So that's like a swap. So you can see in this picture, we're just swapping who, we're donating that organ to. And really that's beneficial for the recipients because then they get a much better match. And we know that they can have better outcomes based on having a better match to someone. We can also do multiple different swaps. So we can do like three-way swaps where we have, multiple pairs in the same chain that we'll call it, again, in order to optimize the outcomes for those recipients. And then sometimes we'll have like this non-directed anonymous donor. We'll call them like either a good Samaritan donor or altruistic donor, where they can actually set off a chain of transplants by donating a kidney. And then, all these different people can get organs, and then potentially even this person represented all the way on the right who didn't have a donor will then be the benefit of getting a living donor from a kidney transplant patient. So again, this is all generally for the kidney transplant population, although we do living donor liver transplants as well, because the liver is so cool. It's the only organ that can like actually regenerate, so it'll grow back. So patients can donate one part of their liver, one of their lobes of their liver to someone else, and then both the donor and the recipient's liver will fully regenerate, it'll regrow. It takes about 3 months or so to do that. Then the other kind of bucket of donors are deceased donors. So we have two categories for this. It's deceased by brain death, where generally their heart function is totally fine, still their respiratory function, but they are unfortunately deemed to be brain dead. And there's different testing that patients will go through to confirm that. But the benefit for a recipient is that the organs are getting blood and getting all the perfusion, all the fluid to them up until the time that we're actually going to take them out, essentially. And so we have good outcomes with those. And a common example with that would be like a stroke that a patient was having. And then the other category is DCD, or deceased by circulatory death. So this is generally somebody that has a non-heart beating, so a cardiac death, a type of donation. Again, there's different regulatory parameters for this in order to proceed with donation. So in general, for the process, one of the big things that a lot of, Donate Life, which is on the slide, and different states will do is have organ donation drives, because really, while we do these living donor transplants, we certainly rely on patients to register. And unfortunately, if they have, some type of, they pass away from various reasons, if they are registered to be an organ donor and have shared those wishes with their family, especially important, and differs depending on what state you're in, the laws around that. But if they're registered, then they can potentially use their organs and give that gift of life to someone else. And a common misconception or myth is if the hospital knows that you're an organ donor, then they're not going to do everything they can to save your life. And that is absolutely not true. We do everything we can for every patient always. But when, it comes to that point where a patient is deemed, without brain function, and we have those difficult conversations with the family about pursuing organ donation. But then the donors will get, complete care up until the time and have that brain death testing just to absolutely confirm that there is no likelihood of them recovering from this. And then every state and even different areas within states have organ procurement organizations, and they really will kind of take over of the management of finding the best possible match for the donor, authorizing that donation with the family, figuring out which organs can possibly be donated to another person, and then overall doing that matching process to make sure that the organs are going to the right people depending on where they are on the list. And all those different factors come into play. And then we finally get to the organ procurement and transplant. And that's where once they've identified those matches and the recipients of who's going to get those organs, then that hospital system, they will send their staff to that hospital of where the donor is. Sometimes it's the same hospital, sometimes we fly, sometimes we drive. It just kind of depends where you're going to go procure the organs. And I actually had the opportunity to go on one of those procurements when I was doing my second year residency, and I took a plane up to northern Wisconsin with the transplant team. And it was really powerful experience for me. The donor, he had had a stroke. He had been brain dead, and we did a moment of silence in the operating room, and the team read a poem that his wife had written and some other sentiments that she had shared. And we all kind of, everyone stopped. And then it's very common for transplant teams to do to acknowledge, this gift that this family is giving to the people that we're going to take those organs back to. And the responsibility of the team in doing those procedures. So then, some more details. So then those organs, they're kept on support to make sure they're still getting blood up until, blood flow and perfusion up until the time that they're procured. And patients are continuously monitored by the hospital and then the staff from the OPO. The transplant team will assume care, and then they'll be in the operating room to procure the different types of organs that are deemed able to be transplanted. And not every organ donor will be able to give all of their organs. It just depends on, various things, how their organs were working before they passed away, and then who the matches are and such. All of the incisions then are surgically closed. So there's no problems with having an open casket or anything like that, which is another common myth in transplant. And then the organs that are procured are taken back to the hospital where the recipients are. And oftentimes, there's different amounts of time that organs can be without getting active, like blood flow. And usually the heart is like the shortest, it's about 4 hours. And so the different teams, if they're coming for different organs, will leave on their own and they'll get back. And so sometimes when it's a time constraint, then the patient who's receiving the organ might already be in the operating room ready for it, so that they can work fast and minimize the time that the organ isn't getting perfused. So we have a huge team. And this is where kind of the transplant pharmacist really comes into play here. But for any transplant team, you're going to have a surgeon because they're the ones that are actually doing the transplant. And then depending on the organ, if it's a kidney transplant, you'll have a nephrologist, a kidney doctor, and then there's always like fellows that are training. So those are usually physicians that are specializing in this area. For liver transplant, we'll have a hepatologist, pulmonologist for lung, cardiologist for heart. Transplant patients are prone to a lot of infections because they are getting medicines forever that suppress or lower their immune system. And so they can develop infections at different time points. So we have infectious diseases team that is often with us. We have nurse practitioners, we have PAs, physician assistants, and then we have a transplant pharmacist, and we oftentimes have trainees too, residents and fellows. We have dietitians, social workers, transplant nurse coordinators, and then, in the inpatient setting, we have the clinical coordinator, which is generally a nurse that is there as well. And all of these people may be on rounds together. And that's one thing that's so important with this team, is having everybody's input and having them all make recommendations, because that's going to optimize the care for the patients. And for us, so the transplant pharmacist, so you can see that transplant patients are on a lot of medication. So they'll get induction immunosuppression, that get this in the hospital to prevent acute rejection of the organ. Then they'll stay on lifelong immunosuppression. So it's usually 2 to 3 medications they'll be on for the rest of their life, because you can have rejection to that organ at any time point. And because of those anti-rejection medicines, they are working by lowering the immune system. So that means that we worry about infections in our patients. So they'll often take anti-infective prophylaxis for various times, which can be about 2 to 4 meds. A lot of our patients will be on acid suppression for multiple reasons. They might be on steroids. They might have risk of reflux. Any surgery, you're going to have pain, so they'll be on pain medication, and with that comes side effects that include constipation, so they may need a bowel regimen. Blood pressure meds, a lot of our patients have high blood pressure and may need medications for that, and we help manage all of this. And then patients can come in with a background of lots of different types of past medical history, diabetes, depression, COPD, asthma. And so, we look at every single one of their other medications to determine whether or not we're going to continue it, whether we recommend changing it, do we need to optimize the dose? And so we review all of that for every single one of our transplant patients, but they can be on a very long list of medications overall. So that's me with one of our former students, Krista. She went to Rosalind Franklin, and she actually graduated and went on to do her first year residency at Northwestern, and then her second year with me in transplant at Northwestern as well. But our responsibilities on the inpatient side are, we go on rounds every single day with the entire team. We review all of our patients' medication profiles. I will say that even to this day, and was a transplant pharmacist for 11 years, there's people that still think I actually work in a pharmacy, and I don't. I barely even set foot in a pharmacy. And this is just showing you a completely different path for pharmacists. I share an office with physicians and nurse practitioners and a social worker and transplant nurse coordinators. I review all of my patients' profiles, do the rounding, or verify orders, new medication orders for my patients. We manage their immunosuppression. So we order drug levels for their medications and then adjust those doses based on them. We order all their discharge prescriptions, do a discharge medication reconciliation with the team to make sure their med list is correct when they're leaving. And then we do their full patient education. So for all new transplant patients, they get an education session with the pharmacist. We go through all, and this is one of my favorite parts, is because you get to be with the patient. And patients aren't usually excited to come to the hospital, but with transplant, they usually are, because they're getting a new life. And so getting to be a part of that is so incredibly rewarding. And then we often have students and residents on rotation with us. So we'll go through patients with them and do topics and as they're learning and these different roles and these different medications. In the outpatient setting, so like in our clinic, we are part of all the selection meetings, which determine who gets put on the transplant waiting list. We do education for patients there as well, both pre-transplant and post-transplant, as much as they really need. We have set visits with them, but if they are really struggling with managing their medications, or maybe a family member was helping them initially and now they're going to be on their own, we'll meet with them as much as we need to, especially if we're making big changes to their regimens. And we'll help with their immunosuppression modifications. And then we have students in our clinic as well. We also are a huge integral part of our protocols and our order set. So these are often set medications that we determine that we will use for different types of organ transplants, and orders that can be automatically put in when a patient comes like out of the operating room. We help monitor all of their labs, their blood pressure, all their vitals. We work with the teams. We do in-services and, preceptor development sessions and all kinds of education for different learners at the institution. And then we help recommend, ways to optimize all of these systems to help optimize patient care ultimately. This is an example of like a med sheet that we would give to a patient. So on the top, we would fill in their name and the date of their transplant and the phone number. And then you can see on the left are the names of the medications, and then we'll put what they're taking it for and any specific notes or side effects we want them to know of. And then we'll fill out like how many capsules or tablets they'll take at each time. So for example, this is a classic 3-drug regimen for a kidney transplant patient, or, liver, lung, heart, honestly, all of them, where they're on 3 different anti-rejection medicines. They all work differently, and we use them all because we work a little bit differently on some of those immune cells and try to minimize having to give one at like super high doses, because then they'd get all the, side effects from that one. So we use them in combination, but they change a lot too. So this is part of why we do such extensive education. The prednisone is highlighted because sometimes we don't always do prednisone in patients. So we highlight that for ourselves to remember to take it off. I mentioned that patients, because they're on the anti-rejection meds, it lowers their immune system. So they may need medicines to prevent infection. So we have 3 drugs on here that are to prevent infection. The first one is sulfamethoxazole trimethoprim, clotrimazole, Valsite. So all of these prevent different types of infection. And again, we fill this out to instruct them how to take it. And then down there you see famotidine or Pepcid, which helps with preventing stress-induced ulcers from surgery, and also from prednisone, and then heartburn. And then the bowel regimen is on here as well, the pain medication. And then we'll have a spot to put in any of their home medications that they were on prior to admission that we're going to continue. And then we have a section telling them what to stop taking. So, for example, patients that are getting kidney transplant, or any of them, are going to be on a whole host of medications that we're managing their chronic kidney disease or their chronic liver disease. Well, now we can, stop those. So we want to make sure they know that they don't need to take those medications. Other responsibilities on our end, we're involved in our quality assurance and performance improvement. We do a lot of case reviews for patients, and really the goals are just to try to find ways that we can optimize care. Transplant pharmacists do a lot of research. We, can be involved as kind of much or as little as we want. It's a lot of clinical research. We have a lot of physicians that like to work with us, and we publish, and we, like to publish our work and different things, because transplant is, it's still evolving. It's still, we've been doing transplants since the 50s, the 1950s, but there's still a lot to learn. And what you'll find is that different transplant centers do things differently. And so that shows you that there isn't a general consensus always on how best to treat every patient. So there's a lot that we can still uncover through research. Obviously, I work at the College of Pharmacy at Rosalind Franklin. So we have transplant lectures within the college. There are some colleges that also have transplant electives. I serve as a residency director for our PGY2 program in transplant pharmacy for 8 years at Northwestern. So it's another opportunity. And then there's a lot of advocacy that we do nationally. We work to try to get more drugs that are approved through Medicare. They've passed legislation covering immunosuppression for lifetime for patients. And a lot of that is based on advocacy that transplant pharmacists have been a part of. There's also a lot of national and local organizations that we do a lot of that advocacy work and a lot of other work too. So ACCP, the American Society of Transplantation. And then what's really cool in Illinois is there's actually, because there's so many transplant centers in Illinois and in the Chicagoland area specifically, there's an Illinois Transplant Pharmacists Association. And it brings together all of our local transplant pharmacists. Every month we have meetings, and there's an executive board, and we have different speakers that come in, and really we get to talk to each other and learn what we're doing, get research ideas, just collaborate and really become friends. Because you'll hear that pharmacy is a small world, and then transplant pharmacy is an even smaller world. And then, so how do you get here? So, initially, like thinking about internship or some type of exposure to pharmacy in general, usually that would be at least for transplant within a health system. Then you would go to pharmacy school and get your PharmD, yay, get licensed. And generally during pharmacy school, if you're thinking about something like transplant or oncology or cardiology, kind of some of these different specialized fields, you'll want to be thinking about residency. And so there's the PGY1 general pharmacy residencies. So I knew that transplant was an interest of mine when I was a fourth year student. So I only applied for residency to PGY1 programs that were at a transplant center. Then there's 49 current PGY2 programs that are specifically in solid organ transplant, and that's usually a year. There are some fellowships that could be longer. And then there is now a board certification exam, BCTXP, that a lot of the transplant pharmacists take to get that board certification for kind of more professional development on our end. Do you want to jump or am I?
Yeah, I'll jump in.
Okay.
That's a fascinating presentation, Dr. Cunningham, and I'm so excited for all of our potential students and prospective pharmacists, student pharmacists to learn about these different career paths. And transplant pharmacy is very unique and interesting, and I know Dr. Cunningham has great things to say. So I just wanted to touch on from an admissions perspective, as future students are looking at programs, really looking at the practice sites at Rosalind Franklin, we are really proud to offer a variety of different practice sites, including those that do have transplant centers. So Dr. Cunningham practicing for many years at Northwestern Medicine, for example. We're 35 miles north of Chicago, so situated right in between Milwaukee and Chicago. So we have a variety of different practice sites, which gives you really unique opportunities to experience different specialty areas. So not only transplant, but critical care, infectious disease. My background is in mental health, and we're right next door to the James A. Lovell Federal Healthcare Center, where we serve individuals experiencing mental health conditions. So we would love to host you in our room today, or if you want to come on campus, we would absolutely love to have anybody for a shadowing session, for classes, to meet some of our faculty, our great alumni, like are pictured on the slide here, who's now a director of pharmacy at one of our local hospitals. So come visit us at the Rosalind Franklin booth, and we'll kind of move back to questions. I know there's one specific question in the chat about kind of the prospect of transplant pharmacy.
Yes.
And moving on to there is some additional resources on our slides too for you.
That's a great question. Transplant pharmacy is booming. I mean, every center that I pretty much know of is hiring. We at Northwestern, there are now 9 transplant pharmacists, and that's not even covering heart transplant. So that's kidney, liver, pancreas, and lung transplant. Because I think, honestly, is that the teams, they see our value and our worth, and so do the patients. And because we do so much, and a lot of these patients are so complex that it takes a lot more time, to spend time with them and to review them and everything. And so, there are so many jobs currently in transplant pharmacy. It's really, really great. And they're both, inpatient and outpatient positions as well. So, and different centers structure their positions differently. Like some rotate, like where you would do inpatient and outpatient. Some are strictly either inpatient or outpatient. But it's a really, I think, a great field. And the accreditation bodies, basically say that a transplant pharmacist has to be on the team. So we love that. And they love us and they need us. And then I did for Donate Life Month, which is in April, I had done a Helix Talk, which is our podcast that 2 of our faculty members, Jamie, jump in if I'm like speaking to this wrong, but they do a podcast. I can't remember how often they publish it, but there's so many good topics in here.
Many different topics that can, like, a variety of just like quick information about those disease states. So Dr. Cunningham has a great topic on solid organ transplant there.
Yes, and we talk about some organ donation stuff, but then there's all kinds of topics. I mean, I listen to it to learn too, to keep up, but a really, really great resource for you guys too. And I think we're like right at time.
Yep, I think we're at time. If there's any other questions, you can jump in, but otherwise we'll turn it back over to Danielle. Thank you, Dr. Cunningham, for
Thank
sharing
you for having me.
Awesome. I
one
think
question.
we have time for one question that I just saw in the chat, and it says, with PharmD and board, can I do resident in transplant pharmacy, or do I need some more prerequisites?
No, after graduation, so what you would do a PGY1, which is the residency right after graduating from pharmacy school, which is a general residency. You know, and there have been residents that have come through and done transplant without, you know, being at a transplant center for their PGY1. But generally we would want to see you had some rotation, some experiences in transplant. But that PGY1 is the kind of the key, and then you would apply for the PGY2 the second year. And that would be for any specialty. So like cardiology, infectious diseases, critical care, pediatrics, you know, there's all kinds of different specialties within pharmacy in the clinical side. And generally it would be PGY1 first and then PGY2.
Thank you.
Awesome. I think we're right at time for this session. If any of our attendees have more questions for our speakers, please do go to their booth in the expo hall. We have about 15 minutes between this session and the next one, so make sure that you're visiting our expo and talking to all of our lovely representatives. Thank you so much to the both of you for this really great presentation, and I hope everyone has a great rest of your day. Thank you.
Thank you.